Well, welcome everybody to Optometric Education Consultants National Webinar Series. Tonight's topic on our Sunday night edition is Glaucoma Update, Enough Pearls to Make a Necklace with my partner, Dr. Greg Caldwell. He's a graduate of the Pennsylvania College of Optometry, where he also did a residency there. He's a fellow of the American Academy of Optometry, a diplomate of the American Board of Optometry, a member of the Optometric Glaucoma Society, and a member of the Optometric Wellness and Nutrition Society. He works in Duncansville, PA as an ocular disease consultant with his primary focus on diagnosis and management of anterior and posterior segment ocular disease. He's been involved in multiple clinical FDA trials. He has integrated nutrition, prevention, and wellness into his patient care, hence his reason to be out in Vegas. He practices truly integrative optometry. He's a co-founder of Optometric Education Consultants and co-administrator of OCT Connect on Facebook. He's lectured across the world and he has served as the Pennsylvania Optometric Association president and served on the AOA Board of Trustees 2013 to 2016. And he has also been named Newsweek Magazine 2023 one of the top 200 optometrists in America. So with that, Greg, please take it away. It's you and me tonight, partner, and we're going to try to educate them all. So take it away, Greg.
Yeah, let's do this. Yeah, it's going to be fun. Let's make it conversational and let's do some glaucoma update for our colleagues here. So with that being said, here are my disclosures. Lectured from Alcon down to Lens, Dompe, Tarsus, and Envision as advisory boards. Nothing really here. I think tonight's going to really touch upon that. Alcon has some medications I might talk about and B&L, but I don't really have any financial interest in any of those companies. I do have a non-salaried affiliation with PharmaNext/Nu Skin. Maybe touch upon that a little bit towards the end and some of the functional part with glaucoma, healthcare registries, chairman of the advisory for Council for Diabetes and Macular Degeneration. Here's really, and I think you guys, everyone's figured out that Joe and I own Optometric Education Consultants. But here's really the key. Here's the 3 points, is that the content of this is prepared independently by me. No one's really telling me what to say or helping me, to be biased. The content of this course is presented without commercial bias. I will be mentioning many products and maybe even medications, but I'm not really claiming superiority with any of this. It's just you have to mention it, and I'm not claiming superiority. But more importantly, CE Broker and through COPE, everything has been disclosed and mitigated. So with that said, here's my practice. I'm a clinician at first, and then scientist. So I don't really, work in a laboratory and growing, axons. So I was just at the Optometric Glaucoma Society. Every year they're talking about axons and petri dishes and growing them and crushing them and checking CMP channels and seeing if they can make that nerve more like titanium and not get damaged. Now, that's all cool stuff to go to. I mean, it was very clinical this year, but they always have to get in a little bit deeper of a science. That's kind of light years away. What I try and do is take the science, Joe and I take the science and kind of translate it and kind of show you how it fits into clinical practice that's out there. So there's the building, there's the exam lanes, and practice 3 days a week, then 2025 going down to 2 days a week in 2026. So with that said, I just want to see if people have heard this term, interventional glaucoma. So I'm going to open up the poll. Oh, wrong one. I should have had it open. All right, here we go. I have heard the term interventional glaucoma. Yes, but not sure what it exactly means. Yes, comfortable with the term. No, I haven't heard it. So that is the polling question. Let's just make sure these are closed. Yep. All right. Right off the bat, interventional glaucoma. Heard it, but I'm not sure. Yes, comfortable with the term. Nope, haven't heard it at all.
And
All right.
no questions yet in the chat room, which you may think would be unusual, but it does happen. Sometimes we start off with questions,
Yep,
but none tonight.
it, it does. All right. I think we got a pretty good sense of what's happening here, a good little snapshot. So I'm just going to display, and we can see that yes, but not sure what it exactly means is 46%. We got about 11% that feel pretty comfortable with that term, and we got 43%. So that are not sure. So we got majority, yes, not sure exactly, or nope, haven't heard of that term. So great. And that's why we're here tonight and to learn about what's happening with some of the trends. So really, interventional glaucoma, I mean, it can have a couple different terms. This one kind of is probably the best one that I've come up with. We taken all the terms together. It's basically a proactive approach to managing glaucoma that focuses on early surgical laser drug delivery treatments to reduce intraocular pressure to slow the process, but minimize the reliance on long-term medication, potentially to reduce the burden of the medication compliance. So two things here is that it's these implants that are going into the eye to minimize the impact on the ocular surface. I always say if you have a glaucoma practice, which I have now for 20 some years, I can see how I beat the heck out of the ocular surface. So if you have a glaucoma practice, you have a dry eye practice, you have an ocular surface disease practice that's out there. We also know that there's financial, and then there's just every day putting drops in the eyes, and maybe people living their lives around putting drops in their eye. So it's kind of approach to minimize the reliance of these long-term medications, to reduce the burden of the compliance, to reduce the burden of the disease process that we cause that ocular surface. When people go to trabs, we know that the more medications they are on, the likelihood that that trab will fail from the fact that all those chronic medications have changed the physiology of the conjunctiva and promotes scarring. So again, it's to try and minimize the amount of drugs, minimize the financial burden that's out there by using these MIGS procedures and these different procedures, and maybe intervening early with SLT procedures that are out there. So, as I just mentioned previously, if you have a glaucoma practice, you have an ocular surface disease practice, and you're seeing the conjunctival changes, the cornea changes, the staining that can occur, if you want to say, from the toxic medications. And maybe it's not the medication, but it could be the BAK that's in it, or the inactive ingredients that are constantly bombarding this eye, especially on those compliant patients, right? So, we talk about compliance, and then when they are compliant, then they get their ocular surface beat up. So, is there a relationship between ocular surface disease and the number of preserved glaucoma medications? There certainly is, and we all love evidence-based medicine. I think we all would agree that we probably would think the more drops being used, that the ocular surface does get beat up. And here's a study here, and it's referenced down below that there was 516 people in this study, and you can see when there was a single drop used, the relationship between ocular surface and preserved medications. Just look at the severe. The more medications we use, the severe the severity or the severe increases regarding that ocular surface disease. Same thing with the moderate, and you can see the milds go down the more you use these medications. So we always love evidence-based medicine. So the number of preserved eye drops correlates severely with the ocular surface disease. And you can see here, these are all the medications, in the United States, and they're great glaucoma medications targeting those disease tissues that we talked about. But you can see the amount of BAK that's in them. BAK is a great preservative. That's why it's used all the time. If you touch the bottle, it's going to really neutralize the bacteria, so we're not creating, putting drops in the eye to create infection. But with that, great antimicrobial and protection that you get with that bottle, what we're also getting is a toxicity to the ocular surface by them using them, once a day. If you're using drops once a day, and then the other drops twice a day, then three times a day. and then adding other medications on top of that could be 5 times a day, and getting that nice now toxic dose of BAK, and you can see the different percentages that are out there. I hopefully we'll get to the part about, talking about the non-preservative. I've been pleasantly surprised by, the generic, I guess, COSOP. I think it's generic. That's preservative free, but the amount of insurance companies that cover it, I just kind of stumbled upon and clicked on it one day, my electronic health record, and it was, like $10 for the patient to pay. So I started using preservative free. And then I had a patient come in the other day that was doing really well on latanoprost, but it was just, irritating their eyes. So I switched them over to some IUSA, and the patient came back and said, "Now this is a good drop." So and their pressure was low, so they were very pleased with that. So I was lucky to have the sample to give the patient a try, and it worked. And now hopefully it's covered. When it was in the electronic health record, it was a very reasonable copay. I mentioned it to the patient, and they said, "Yep, not a problem. For the amount of comfort that I'm getting out of this, it is definitely worth it." So you can see just switching to preservative-free latanoprost, you can see that the conjunctival hyperemia, the blepharitis symptoms, and the tear breakup time improved, and the symptoms of blepharitis and hyperemia went down. The BAK, talking a little functional if you want to go, is that, we do have a normal flora, just like we have in our gut. We have a normal flora that lives on our eyelids. And whenever we're treating glaucoma and that BAK gets onto the ocular surface, it's not going to, it's there to preserve the bottles. If you touch the tip of the drop, it's there to help keep those drops preserved, but it's now going to disrupt that lid microbiome that's on the ocular surface. So maybe that's why we do see some blepharitis and meibomian gland dysfunction and that neovascularization of that lower lid when we're using these preservative-free. So this is the reason why I asked this question in the poll was, do we consider glaucoma an inflow versus outflow? And what is glaucoma? And 70% or 75% said, or maybe it was 80 some percent that said it was outflow. And so that's why I always like to review the outflow. So we do know that aqueous produced ciliary body flows through the pupil, front of the lens, through the pupil, and the majority, because some does exit through the posterior, through the retinal, maybe choroid, which is about 3%. The rest of it goes through the anterior chamber and out through the trabecular meshwork. And then after trabecular meshwork, this is really what I want to really drill down, is it gets into Schlem's canal, and then has to go through a collector channel. Then once it goes through the collector channel, it gets to the venous plexus, then to the episcleral veins, superior and inferior orbital veins, and then into the cavernous sinus. Okay, so that's really how the aqueous drains out. But I really want to kind of take a little deeper dive into Schlem's canal, into the collector channel, because I'll just disclose it here, or just kind of unveil it here so you can kind of see where I'm going, is that I don't have glaucoma. And so my trabecular meshwork tissue is totally different than the trabecular meshwork of my primary open angle glaucoma patients. That trabecular meshwork becomes sticky. It becomes oxidatively stressed. It doesn't perform the way it should. It's just not as healthy. There's something wrong in a sense with that trabecular meshwork. And what I really want to point out is that it becomes sticky. So now what happens is, if the pressure builds up and Schlem's canal collapses and the trabecular meshwork is pushing against the posterior wall, it might stick there, and now we can't get the aqueous into Schlem's canal. It's that's kind of, that canal has collapsed, and that trabecular meshwork being sticky, kind of Velcro-ish, sticking against that back wall. Now we've got the collector channels blocked up. So think of that tissue It's kind of like someone that's insulin resistant, right? The muscle of an insulin resistant person is totally different than someone that is more metabolically fit or someone that's working out. The muscle is going to be able to, and someone that works out is not insulin resistant. The mitochondria are different. It's not as fatty. It's more of a prime. It's more of a fillet than a prime rib that has fat in it. So the tissue is different in a primary open angle glaucoma patient. And Tom Freddo here has done some great work, and he shared these slides with me, and I thought it was just great work that he did. Is that this is the trabecular meshwork, and he's showing Schlem's canal, and then the CC here is the collector channel. And what he's doing here is he's increasing the IOP up to 30, and you can see that the trabecular meshwork down here has herniated into the collector channel. And then what happens is as you lower the pressure, what you're hoping is that the trabecular meshwork will come away from the pull out of the collector channel as it's herniated up into the collector channel, or it's sticking against the back wall of Schlem's canal. You would hope that what would happen is Schlem's canal would open up and allow the aqueous in to get out through the trabecular meshwork. And here is, a classic example here of someone that has a pressure of 0, but yet because this trabecular meshwork is not, it's abnormal. It's not normal. It's herniated into the collector channel, and it's not unplugging. So now we've kind of have a clogged sink. We got a clogged toilet here, and that's maybe sometimes why some of these treatments failures work because even if you can, laser the trabecular meshwork, maybe it still doesn't allow that aqueous to drain out. So he's showing here a pressure of 0. Here's Schlem's canal. Here's the herniation. So I want you to realize, kind of from a physiology standpoint, that this trabecular meshwork tissue is different. And I remember when I was helping with launching some of the trabecular meshwork, the prostaglandin analogs over the years, I met this guy Michael, and he was a medical science liaison. He had his PhD, and some of his work in getting the PhD was trabecular meshwork tissue, and we literally sat down for about 4 hours one night and just drank a wine, and just I learned so much about trabecular meshwork that just like every our body's amazing. That tissue is extremely complex. The different receptors that are on it and the different things that happen to this tissue, and that's just in primary open angle glaucoma. So what we want is, in a normal eye, is that the trabecular meshwork is not sticky. It's healthy. If it does herniate up into the collector channel, when you lower the pressure, Schlem's canal opens up and the trabecular meshwork, allows the aqueous to flow through. But as it becomes oxidized, as it becomes sticky, then it can herniate, and you can see the Schlem's canal and the collector channels are not able to drain the aqueous and get to the venous plexus, get to the episcleral, get to the superior oral fissure to drain out into the cavernous sinus. So just connecting all the dots and just trying to just put all these dots together. When I was helping to launch Natarsadil, I was one of the speakers for ARI at the time. This asset now, the Natarsadil product, is now with Alcon, and that would be, what the combination is Rocklatan or Ropressa in the single agent. And this was during the slide deck was just a picture's worth 1,000 words. Is that disease at the trabecular meshwork is responsible for the elevated. So again, I agree with the audience that was out there in the polling question that it's a disease of outflow. We got a trabecular meshwork, Schlem's canal, collector channel type of issue. And they were just showing these pictures here of healthy trabecular meshwork in someone that is, if you want to say doesn't have primary angle glaucoma. And you can see over here the tissue has changed. I mean, you can look at that. It doesn't look healthy. It doesn't look flexible. It doesn't look like it's going to allow that aqueous, which is sitting in the anterior chamber, trying to get the Schlem's canal to the collector channel. It's just going to kind of get all backed up, and then the intraocular pressure goes up. And then here is, the cellular damage and oxidative stress. So, this is why it gets confusing for us allopathic docs that are out there as we're treating glaucoma, primary open-angle glaucoma. People want to know, why do I use the hand scanner on my glaucoma patient? Or now it's the finger scanner that's been rolled out that we were helping release here at A4M, is that you could see here that, when it comes to chronic disease, I guess I'll pause, is that when it comes to chronic disease, it needs to be more of a strategy. It's not an acute or linear. Oh, you got glaucoma. I'm going to put you on trabecular. I'm going to put you on a prostaglandin analog. That's it. Linear binary. I'm going to just put you on that. When you have a chronic disease, whether it's diabetes, whether it's dry eye, whether it is glaucoma, there has to be a strategy in place. So, okay, I'm going to put you on a prostaglandin analog, but can I do things like fish oil and some antioxidants to take away some of the oxidative stress, to take away some of the cellular damage that's occurring? And the studies are out there that show, yes, it can be done. So, I'm just going to treat glaucoma with fish oil and antioxidants? No. I mean, it's not going to change the tissue that much to drive back and reverse what we're seeing in this picture, but will it help take away some of that stress, and will that help me years later on down the road? I believe that it does. So it becomes part of a strategy that we can do things, and that's your allopathic side, latanoprost. And hey, patient, you've got primary open-angle glaucoma. The evidence is out there that you have sticky disease. I mean, I geeked out with a guy for 4 hours about this. And so, can I help a patient with this strategy by doing that? I hope you see now why I go down that path. Now,
Hey, Greg,
yep,
before you
go
go
ahead. Go
on,
ahead. Good.
going back to the changes in the collector channels, question rolls in: do any of these changes in the meshwork or canal or collector channels cause any visible changes in when we do gonioscopy?
Yeah, that's a great question. I don't think I have enough magnification to be able to look in there to be able to see those changes, to be able to tell when I do gonioscopy. I might see some of the pigmentary changes that are occurring if someone's pseudoexfoliation, but I think you kind of have to be at this kind of electronic microscope to be able to see those cellular changes. You might see maybe some closed, angle or some synechia out there, but I don't think where our magnification is high enough to kind of see these changes at the cellular level. But Joe, your thoughts? I know you do a lot of gonioscopy.
Well, I agree with you. It would be great if we could identify where collector channels are. I mean, theoretically, when you punch a hole in with a stent, can you get into the collector channel?
Yeah, I mean, you can get in there, but it's whether or not now, as we show some of
Just
these
we
devices,
can't find them.
right? Right.
Which
I
could
mean,
also explain why somebody fails on a MIGS procedure like an eye stent, and another person is well controlled. Maybe the surgeon hit a couple of collector channels, and another surgeon didn't find them. I mean, it's not their fault. You don't know where they are.
yeah, taking a little theme of Vegas, that where I'm doing this from. It's kind of a roll of the dice, for lack of a better term, that's out there. So we had our previous speaker on the other day, Jeff Bannis. He did a great job of kind of hitting all these technologies, and he works with a surgeon, Paul Singh, who does all these, and he helps manage the studies and sees all these great MIGS procedures and laser procedures. He did a really fantastic job, going over some of the latest innovations that's out there. I'm going to kind of hit on kind of the ones that are kind of from the past and then it's still being used now. And Joe kind of highlighted with this, here's the eye stent. This is where kind of that first MIGS procedure came out, where they used this snorkel procedure and stuck it in and tried to get it in, maybe peeling some of that, you know, trabecular meshwork from sticking against the back surface of that of Schlem's canal. And then you would hope that when they put this eye stent in, that maybe on the adjacent side that there was a open collector channel. And but the problem is, you don't put a dye in the eye to know if it's, you're putting it in a part of the eye to where the collector channel is open. So again, it was kind of a roll of the dice, and that's why we had some failures that were out there.
Yeah,
And then
the other
as
one, Greg, the other one, if you go back, the eye stent, the original one, when you stick it in, it kind of goes in Schlemm's canal, and it gets aqueous in there better, but it doesn't, and it bypasses the trabeculum, but it doesn't do as much, in my opinion, about puncturing a collector channel as what you're about to show us, the second one, the eye stent inject.
So here's the eye stent inject, just try to increase, try to get near that collector channel, try to get into Schlemm's canal, try to puncture to get through and try to get that aqueous from the anterior chamber through that, again, that diseased trabecular meshwork, which isn't healthy. So there's been some different renditions that come out. You know which ones that your surgeon used. There was the iStent inject, then there was the iStent inject W. Now we have the iStent Infinite that's out there, and you'll see here that um, Joe, did I start the sound? Can you hear the sound on that?
I cannot.
Okay. I'm not sure if I should try to pause. I forgot to share the sound here. I'm not sure if I'm going to create an issue here, but we're going to try and come back. We're going to share sound. And I'm going to hit play again. So let's see what happens here. Let me reverse it. Tell me if you can hear it now, Joe.
I can.
Perfect.
Okay, here's a patient with refractory primary open-angle glaucoma. Patient's on 4 classes of topical medications, and pressures have been hanging out in the low to middle 20s. I'm entering the eye now with my iStent Infinite loading device here. I'm going to address the TM right across from my main wound. Gentle pressure, pressing the delivery button, holding, and then coming back out. I'm going to go 2 clock hours to the left here, using my wound as a fulcrum. I'm going to press that singulator, that purple button. I'm going to press that button to get the next stent ready to go, and then put gentle pressure, press the delivery button, and then come back out. I'm going to go 2 clock hours to the right now of that first stent. Again, same thing, press the singulator button to get that next stent ready, put some pressure, press the delivery button, come back out. So now I have 3 eye stents into the nasal canal, 2 clock hours or so from each other. You see that reflux of blood? That indicates that we have probably some good access or good patency in the canal and the collector channels. Now watch that arrow on the right. Talk about blank.
Now I'm going to pause because I see the arrow up here. So now, when he put these in, if he's by a viable collector channel, it's going to go through that venous system, and you're going to see when he uses like balanced salt solution, you'll see those veins clear. If that collector channel was blocked, okay, it's great to put that eye stent in there, get that aqueous into Schlemm's canal, but now we can't get it into the venous system, which is the very beginning of that. The opening is that collector channel. So he gets excited here because you'll see that he'll call it the fluid wave. You'll see that vein will now become clear because that's the BSS in there. So watch.
Watch this. Look at this. Ready? The whole episcopal system wipes out. Now watch that blood vessel there, right? That arrow. Ready? Look at that fluid wave. Incredible. We go slow motion here in high mag. Watch that blood vessel one more time. Look at that fluid wave. Incredible. This is, I think, pretty unique. And we have 3 eye stents here. And I think it's important to recognize that we don't know where the resistance to outflow is preoperatively. Where are the collector channels? Where are they patent? Which ones are actually functioning well? Where's the canal patent? I think having 3 eye stents really does hedge our bets. I think that 81 micron lumen is enough to improve outflow facility. It's just a matter of where are they in relation to the collector channels. So having those, I think, 3 stents really, I think, does make a difference. We've seen that so far with the data on the ones that we've done. Hope this.
Nope. So basically, here down here is the 80 micron diameter he's talking about. You're going through the diseased trabecular meshwork. The aqueous is now able to get into Schlemm's canal, and hopefully you're by a viable collector channel. And you saw from those fluid waves that was that was the outcome. Here's another one here. The goal is to increase. So you'll see, but before the eye stent was put in, you could see that the dye was very minimal. After you put the eye stent in, you're getting past that again, diseased trabecular meshwork, allowing the aqueous to get into the Schlemm's canal and then into a viable collector channel. So you can see that this is before and this is after. But this is why as we mentioned that it's a roll of the dice that you put an eye stent in. And at the time, there was only one allowed, and then hopefully, if you weren't by it, hopefully you were by a patent collector channel so that you could get this positive outcome from getting through that disease trabecular meshwork. Here's another one showing that the blanching. You'll see it down here as I play the video. You'll see that the fluid wave, and what's happening is they're just putting BSS, which is a clear fluid, and then as it goes in, and then it fills back up with blood. So it's just kind of just the balanced salt solution just going through the system, and then it fills back up from the other capillaries that are filling that vein, other drainage areas with blood, filling that back up. So it's just showing you that things are patent when it's coming through that collector channel into that venous system. All right, so let's see here. How do I go to the next slide? So here's a Cohook dual blade, right? This is kind of just trying to fix the whole idea is going in and using a dual blade and using a sharp point and cutting out trabecular meshwork, kind of two razor blades on one side, hitting the anterior and the posterior, or I guess the superior, inferior, depending on how you're going around, but hitting that edges of just cutting out a section, taking you right from the anterior chamber, cutting out the trabecular meshwork, kind of taking the leaves out of the Schlemm's canal, and then hopefully you don't have tissue that you're cutting off and that's herniated or plugging up the collector channel, or maybe over time, since there's really no wall there, that it would potentially fall out and help the aqueous. So this is just taking out the whole trabecular meshwork.
This is
here
Brandon Bartman
by
demonstrating
using
the
this.
use of the KDB Glide for excision of trabecular meshwork. Here I'm using a mark and meet technique, which allows for precisely 3 to 4 clock hours of trabecular meshwork removal. The ramp and dual blade nature of the Glide allows for a lifting and stretching of the meshwork with little resistance and virtually no leaflets of tissue left behind. Here I am using a cohesive OVD to not only tampen out any blood reflux, but also directly deliver OVD to power wash the canal and open the access to collector channels. You'll see when initiating irrigation after the procedure is complete a blanching of blood vessels in the exact area of the goniotomy, indicating a reduction in resistance to outflow. Lastly, with this technique, the eye can be left at physiologic pressure with minimal blood reflux. Thanks for watching.
So that's why it's important to understand that diseased trabecular meshwork, it's sticky, it sticks to Schlemm's canal, collector channels can get clogged up, and if we have that issue, I heard him say he's power washing out maybe some of those clogged collector channels from the tissue that's kind of herniated up into there, and that's what we're doing with the canaloplasty.
Hey,
You're going to see. Yes.
Before
yes,
you go on, just a word about the Cahoot dual blade. That is really just a modified goniotomy, and that was always considered child's play, so to speak. And what I mean by that is it was only for developmental infantile glaucomas. Now that's an entirely different disease. Now the Cahoot dual blade is like a cheese slicer. I mean, it's taking all that tissue out. And that's very important to understand. The issue with goniotomy, when it was done historically, it was done with a goniotomy knife, and they just cut across and made a slit. Now there's a different disease in infants and toddlers, but they cut it. The problem with that is it heals. And that's why they never did it with adults. Because if they just cut across, yeah, eventually it will just heal. This is sucking and removing all of that out. And I think, and that's why it is now successful in goniotomy, is now more than just for kids.
There we go. So good history and good review, and kind of more of that understanding the pathophysiology of this condition and what we're trying to treat here. So here's a canaloplasty. Again, just a different procedure to kind of go after this diseased trabecular meshwork, literally kind of filling up Schlem's canal with viscoelastic to kind of re-expand or to maybe take that sticky trabecular meshwork off that back wall, as you'll see here. So it's just kind of this
Hi, this is
diseased
Don Lee
area.
from BVA Advanced Eye Care, demonstrating the new Streamline surgical system by New World Medical. Streamline allows for the creation of multiple precision goniotomies across several clock hours of the trabecular meshwork while delivering OVD into Schlem's canal. The amount and degree of goniotomy incisions is completely titratable to the surgeon's preference. Streamline injects OVD when the actuator button is depressed, leading to dilation of
So I just want to point out, he's poking through the trabecular meshwork and then basically putting a viscoelastic coat in there just to kind of blow it open again in this canaloplasty. You kind of hear him saying that he's trying to reopen up that canal.
Schlem's canal, stretching the TEM and flushing the collector channels. OVD injection into the canal lifts the TEM and allows the incision to take place far from the anterior wall of the canal. As seen in the video, the blue sleeve acts as a guide to keep the inner cannula directed along the trabecular meshwork when sweeping to the left and right. The inner cannula is only 150 microns in diameter, which is smaller than other catheters used to create incisional goniotomies. The rounded distal tip was designed to lift TM over the cannula rather than pushing the cannula into the canal, thereby minimizing chances of injury to the anterior wall of Schlem's canal. The streamlined design truly enhances the surgeon experience and control during angle surgery, and its broad indications allow surgeons the option to utilize the device in all severities of glaucoma in conjunction with cataract surgery or as a standalone procedure. My own personal experience is that streamlined patients have much less post-op day 1 hyphemas and red blood cells, most likely due to the small size of the goniotomies. Thanks for watching.
So that's kind of, enough. We're folding back to, to interventional glaucoma. They're doing these procedures, try to get in there, try to get the disease part, this outflow system working, reduce the amount of drops, try to get the pressure down. And that's why you're seeing so many MIGS procedures being done that's out there. The Zen gel stent, it kind of just bypasses this whole diseased trabecular meshwork. As you can see here, they're coming through from inside the eye, going above the trabecular meshwork, going through the sclera, going through Tenon's capsule, but not going through the conjunctiva, and laying in this gel stent that allows the fluid to drain out, kind of almost like a candle wicking type of procedure to kind of create this bleb that's out there. But again, not even just saying, forget you trabecular meshwork. We're just going to go right above you and go out into the conjunctival space that's there. So you can see the gel stent is here. You can see that the surgeon is coming through the eye, putting it underneath the conjunctiva, and creating just a whole bypass of this whole diseased trabecular meshwork. As we mentioned earlier, the part of where as we said, it's a disease of outflow, not allowing that aqueous to flow out, and then it creates all this physiological or loss of homeostasis, and then we get ganglion cell loss and nerve damage.
Hey, Greg, do you remember when we did an exercise where we did that in the wet lab, you and I?
Yeah, I do recall. I forget where that was. Might have been at the academy.
I don't know. I don't remember where it was. You did pretty well, whereas I gave the mannequin endophthalmitis.
Yeah, we were able to treat it. That was able to be treated very, very, very quickly and very successfully. So I do remember that. That was a fun experience that we were able to put those in. So I think we did those. What, they were like cow eyes or something? I forget what type of eye.
I think it was actually a mannequin I gave endophthalmitis.
So this was the original that came out back in the day. I think maybe some anterior segment surgeons still do it. It's kind of going back to the OG. Just a kind of a quick reminder. The endoscopic cyclophotocoagulation, ECP. And it's just a nice little quick video. We said it's a disease of outflow. This is why you don't see a lot of the glaucoma surgeons doing it. They understand the concept. They understand that, you're lasering part of the ciliary body. You're killing off some of the epithelial cells to slow down the amount of aqueous being produced. A lot of the cataract surgeons would do it at the time of cataract surgery because they would, phacoemulsify the crystalline lens, and then what would happen is they would have access to the plica here of the ciliary body, and they would go in and laser there. So I'll just play the video here. I think the video is worth 1,000 words. And what you'll see here is, you're going to see as the surgeon goes across, you'll see that the tissue will turn white. And it's not that they're, shooting, aimlessly here. The two red beams that you bring together to focus just didn't really pick up well or at all on the video here. So it's not that they're shooting, well, you're kind of aimlessly here. You just don't see the aiming videos. But let me just play the video. And you'll see that the tissue does respond. It does turn white. It does shrink up. Surgeon moves on to the next area and the next area. And every surgeon was a little bit different. Some would treat 180, some would treat 270. And what they're just doing is just killing off the epithelial cells on the ciliary body that are produced in the aqueous. And, that's, you're not making, there's never been a case of hypotony. There's plenty of epithelial cells around, but the glaucoma surgeons were like, hey, that aqueous is very, is very important to, cornea tissue, the endothelial cells and the cornea and the crystalline lens and other tissues of the eye. So, maybe we don't want to be reducing it. I'm not sure if there's any been long-term effects from ECP, from reducing aqueous, maybe from a nutritional standpoint. But that's why you just never really see in the glaucoma, community really, gravitate to this. It was done a lot of times at cataract surgery. Go ahead, Joe.
Fortunately, people really are not doing this, or they shouldn't be doing it. There's two major problems. Now three, when you mention the homeostasis and health of the needed aqueous. But in many eyes, it gives this persistent flare that just never goes away. But I think the biggest issue, at least for me, is there's no studies that show it's effective. They do it, but there's no really clinical evidence or randomized clinical procedures that have shown it works. They just do it because it worked externally, albeit with a lot of inflammation. So they figure it must work internally, but there's just no science behind it.
Yeah, so I think that's why you see that, it's kind of died off. I think it's still out there every so often. You'll see, an anterior segment surgeon doing it, or, cataract surgeon doing it, because they just have access to the ciliary body when they do this. This patient, what they do is they phacoemulsify the lens, put a few little extra viscoelastic in, and they use a camera, kind of expand everything out. They go in, and then they go back, put the lens in, and do it. Or maybe they do it with the implant in and just kind of expand that, behind the iris and in front of the IOL, that space, and they're able to access that. All right, so I'm still going to hit this hard because every time I do a live lecture, there's still some confusion out there. So I'll just keep doing it. Joe knows I'm going to keep doing it until, we kind of get to where this is. So I'm going to launch the poll here. We got two polls here. And what we're coming down to is asking is, we have two patients. Oh, I guess I can expand the next one. We've got two patients here. One has a 500 micron central cornea thickness. The other one has a 600 micron central cornea thickness. They both have 21 millimeters of mercury on Goldman applanation tonometry. What is the true IOP? Is in the 500, is it a very thin cornea? So now we're going to, assume that, that cornea is thin and it's 24. So is it, 18, 21, 24, or you don't know? In the 600 micron cornea with that 21, is it 18? Is it 21, 24, or you just don't know? So what is the true IOP that's out there? Kind of let those roll in.
We're good on the questions or the chat room, so we're fine there.
Perfect. You're going to see me disappear here real quick. I'm going to let that roll. I have to take care of a little runny nose here. Hold tight.
Okay, everybody's rolling in, doing very well. I like the responses.
All right, I'm back. Okay, so I guess we can show the results. So let's do this one here. So with the 500, I can say that there would be two answers that I would go with. I would go with 21, which was what 36% of the people, or 15% said I don't know. We have 37 wanting to raise that IOP. I'll come back, I'll close it, and then we'll show the results of this one. Here's 600. If I was replying, I would say, okay, 21, or you don't know. So I would give 21 being B, or you don't know, 14. I wouldn't go with 18 and lowering the IOP because it's a thick cornea that's out there. And I'm going to continue to go over this and go over it until we start getting some resolution to this. So we have a 500 micron cornea here. And I know for years it was taught when the PAC integers came out and the ocular hypertension treatment study came out that, we're teaching, adjust IOPs up and down. Here's the issue. The cornea is a complex tissue. And I kind of showed it a little bit earlier. There's cornea curvature, cornea thickness, cornea rigidity. I don't know. I think there's like 21, 22 different biomarkers, the horizontal visible diameter, all these different cornea biomarkers that are out there. And we're talking Goldman. How many of you, when you get above 2 diopters of cornea astigmatism, adjust your Goldman to match? That's what those degrees are on there. I think it's two prism. I think it's 2 diopters of astigmatism. That's why you have those lines in that. When you look at your Goldman, we all set it flat, but you're supposed to adjust it and do the IOP because it makes it more accurate when you have a highly astigmatic cornea. None of us do it. I don't do it. Again, we're taking we're doing transcorneal IOP measurements, and we're making this huge assumption that a 500 micron cornea is wimpier or easier to indent than a 600 micron cornea. But what we're doing with that assumption is we don't know the cornea rigidity. And there's been plenty of studies come out of the optometry schools that there are 500 micron corneas that are, I'll knock on my microphone here. I'm not sure if you can hear it, but some of your, 500 micron corneas are super rigid. And that we make this assumption, human error, human assumption that 600 micron corneas, man, they must be rock hard. So you got to crank that tonometer up. So that IOP must have been 18, but they showed in plenty of studies that the cornea rigidity of some 600 micron corneas are not as rigid, right? So 500 micron corneas could be really titanium, and 600 micron corneas could be super mushy. There you just introduced human error. So in this, if it was Golden, if I was answering it, I would say, okay, 21, or you don't know in both cases, because you don't know the true IOP. But if you were just going to just take it, I would just say it's 21 and don't adjust up or down because you might go the wrong way on the patient. Again, knowing the cornea, not knowing well, the cornea curvature, but how does that influence the golden tonometer, along with the thickness, along with the rigidity, and all the others? So my advice is, please do not adjust up or down on the goal on these. Take the IOP for what it is, and here's what you use cornea thickness for. It is a risk factor. I always use the analogy. Everyone on here tonight is at risk for retinal detachments. Who are the patients at higher risk that are on here tonight? Those with a higher axial length. So you're at risk for a retinal detachment with your high axial length that's out there. Everyone is on here is at risk for lung cancer. We all have lungs. We're all at risk for lung cancer. Who are the ones in our patients? Who are the ones that are at risk? Those who smoke, maybe those that vape. Those are the ones that are higher risk. We're all at risk for glaucoma. Who are the ones that are higher risk? Those with high IOPs or those with thinner cornea. So use it as a risk factor, but they have to have a high IOP. Someone that comes in that has a 21, or let's even say a 22, 21 or 22 with a 500 micron cornea, I tell them you're just a poor LASIK candidate, right? We can't say that they're at higher risk for glaucoma. There wasn't a study. The ocular hypertensive treatment study said that you had to have a pressure of 21, or I'm sorry, 24 or higher to be enrolled into the ocular hypertensive treatment study. So if someone comes in and has a pressure of 21 and a thin cornea, 500 micron cornea, to me, it doesn't really tell me anything other than they're a poor LASIK candidate. Maybe they become a better PRK candidate. But I don't have a study, as Joe talked about, with evidence-based medicine that I can plug someone into because they had to be 24. That's there. Now, if you have a person with 26 IOP and a 500 micron cornea, I wouldn't adjust it up or down. I would just say, based on the study, you were found to be at higher risk of conversion. If you come in with a 600 micron cornea, the study just shows that you have a little bit of a protection or a little bit decreased risk from. I wouldn't adjust up or down. I wouldn't say, oh, that's because your pressure of 26 is more likely because it's 22. No, we just found that people with thicker corneas had decreased risk and people with thinner corneas had increased risk. So please, don't adjust, up or down. So here's kind of something that I thought was kind of, ironic. This was a patient that came into mind. I gave him great care. He had PRK, he had retinal detachment, I believe, as we go through. Yeah, here's the scleral buckle. He had PRK done, and I refracted him and took care of him, and I think I got him better than this acuity here, 2040. I think I had him down to 2025, maybe 2030. He's 2030 or 2025 in the left eye, and but he wants things to be perfect. So he went and saw, an ophthalmologist, which is fine. I'm not making any OD or MD type of, but he went and got another opinion. And as I read through, I said, oh, this guy went for another opinion, but in his glaucoma suspect, he had thicker pachymetry, 550, 590, the correction factor. And I'm like, oh my goodness. Now we're correcting in that left eye because of this thicker IOP or this thicker pachymetry, we're driving down by 4 points. I mean, how are we making that assumption, right? That's out there. So again, don't adjust IOPs up or down. Even if you see other people doing it, it doesn't make it correct. All right, Joe, any comments, any questions on that?
There are two questions, but I know you're going to be covering them shortly, so I'm going to table them for now.
Okay. So, there's different ways to be able to do pachymetry. Here's ultrasonic versus optical pachymetry. So here's an orb scan technology. We got the posterior float, we got the anterior float, but it also has these optic sections in there, and it can hit the anterior, hit the epithelium, hit the endothelium, and be able to give you what's called an optical pachymeter. There's also ultrasonic that we grew up with to be able to get pachymetry readings. There's also ways you can use your OCT. Now, this is going to be more accurate, and I believe Joe and Lori did a study on this, showing that it was about an average of 8 microns thinner when you did OCT pachymetry as opposed to ultrasonic. And the reason being is that the OCT can make this a right angle and go straight through. And when you use ultrasonic, if you're off just a degree or two, now imagine you just not being perpendicular here, and now we're going to go down this way. I'm going to over exaggerate. If you're just a little bit off and you're not perpendicular, you're not, that's not the shortest distance. So on average, you're going to be about 8 microns thicker on ultrasound. So you can use OCT to be able to do that. This is kind of how I do it in my practice. The first
And
time
Greg,
someone, yep.
also in that study we noted that the reproducibility was much greater with OCT.
I mean, no surprise, right? I mean, you're using something that can get down to microns, versus using someone that has a hand and you're trying to get centrally located. So reproducibility and that 8 microns, which is a great, valuable study to kind of say, like, let's do some, OCT measurements. So here's how I do it in my practice. I have, this ability to be able to get all this data here. Let's go back to Joe and Lori's study. So here's the thing: is they should be within about 8 microns of each other. What happens if you have someone that's 590 and 540? Oh, geez, we're 50 microns. Taking out any corneorefractive surgery. My advice or my clinical pearl for doing this for years is that when they're that asymmetric, probably look at the cornea a little bit closer. You might be missing a some type of pathology. It could be anterior basement membrane dystrophy, or it could be Fuchs dystrophy, and you're picking up on some early swelling. So if you're using ultrasound, or if you're even using OCT, you might be able to pick up on some cornea disease. Now, here's one here that I'm showing you. It's a little bit thicker. It's a lot thicker here superiorly. I'm using this on a Fuchs patient. I'm just monitoring their cornea thickness and all the different sectors here centrally, and the eight to 16 sectors. I didn't count them, but how many different measurements there are around there to be able to monitor to see what's happening with this patient and their Fuchs dystrophy. But you can see here it does give you a central cornea thickness on this patient. There's your asymmetry that you can tell that there's a cornea disease going on. And obviously, I told you it was a Fuchs patient that I'm monitoring. These are actually my eyes. I had LASIK in 1998, and you can see here that they're thinner here. We have 431, 447. These are after a LASIK procedure. Now, all of a sudden I'm not worried about, like, oh my gosh, my corneas are thick, or thin. Now I have a higher risk of glaucoma. If someone has LASIK and they have glaucoma, you want to go off. If you want to use pachymetry as a risk factor, high or low, based upon their IOP measurements, then you would just want to know their original pachymetry readings. So, Joe, did I cover what you thought I would cover with those questions that were in the chat box?
No, the questions were involving hysteresis.
Okay, it's coming up right now then. All right. So, with that being said, cornea hysteresis is a very powerful biomarker that's out there. There's more than one way to get that intraocular pressure. There's more than one way to skin that cat. When I was at the OGS meeting this year, they spoke very highly of cornea hysteresis. It was actually kind of funny that one of the glaucoma docs, they were like, listen, I don't care what your pachymetry is. What is your cornea hysteresis? That's what I want to know. And that's how important that person felt that it was. So we're going to play this video here. And what cornea hysteresis is that it's got this same little bump here in this little video. The same bump is over here if you look real closely. But this tire is not bouncing around as much as this tire, because this shock and strut is a little bit able to control and dampen that bouncing. So which car would you rather be riding with? I guess if you want to be bounced around, you'd want to ride in this one. If you want to have a smoother ride, you'd want to ride with this shock and strut. So what is cornea hysteresis? What is it all about? And why is it becoming an important biomarker in glaucoma? Is that it reflects the cornea's or the eye's ability to absorb or dissipate energy. It's basically, what we just showed you here. When someone has a high cornea hysteresis, it's like this tire on the left. And when someone has a low cornea hysteresis, it's like a tire on the right. It's the eye's ability or the cornea's ability to dissipate or absorb that energy. Now, I have about 6 ways in my practice that I can evaluate intraocular pressure. I do have the ocular response analyzer. I'm not claiming any superiority over it. Not claiming any superiority over it because I have it. Just saying that I have it and I'm experienced with it and I feel comfortable talking about it. So what it shows is that it has a wave score as a reliability. My technicians know I like at least a 7. I will take a 6. It's a 0 to 10 score. I like 7 and above. So they try and get the patient not blinking, getting their cornea to wet, just to try and get a great wave score. So that's just your quality score. Then you get a Goldman equivalent, and it's not going to be whole numbers like 16, 17, 18. Will have 16.1, 16.2. They have tenths. And then you could see, based upon the cornea hysteresis, which I'll come back to, it will, in a sense, give the cornea compensated, or what they call closer to true IOP, based now upon some other dynamics and the cornea hysteresis. So it is adjusting up or down. I do look at both of the numbers, and the average cornea hysteresis is 10.5. So when it's 10.5, 10, 9.5, 10.5, 11, that really is showing here, down here, 11.5. Man, that's really lowering the risk of glaucoma in a sense. So it is a biomarker. It's a very powerful biomarker for the increased risk or decreased risk for the development of glaucoma. So here I have some of these. These are that heat treated paper, and I was tearing them off, saying, "Oh, these are great. I want to be able to use these for my lecture." And then they started to fade over time because, it's that heat treated paper. So I think I got them kind of cleaned up enough that we could see them. They were really fading over time. This one here is just to kind of show you the wave score. This is one of those I'm gonna be like, okay, I'll take a look at it. Luckily, the IOP is nice and low. It's 11.1, 11.6. Here's your cornea hysteresis. Again, I'm looking for around 10, 10.5. These are 12. So what you're going to see is they're going to say, okay, based on that cornea hysteresis, that transcorneal IOP, which is 11.1, inside the eye is most likely 9.6. And this one here is 11.6. And because of this cornea hysteresis, it's around at 11.7. Now you gotta be careful because of these wave scores really aren't really the best. Now we jump down to a little bit better of a wave score. So we got the 8.2s, 8.9s. I like them 7 and above. Here we are with a 26.6 and a 25. Here's a 9.1 and a 9.5 cornea hysteresis. This makes me exhale just a little bit. So that 26.6 is a 27, this 25 is 25.1. That eye's ability, that cornea's ability to dissipate that energy is a little bit high. So that's good. That's what you want. Now, again, wave score 6.3, 7.1, a little bit low, but I'll accept it. We got a 14.8, 13.6. Now we're getting to a little bit lower of a cornea hysteresis. When they start getting around 6 and 7, there's not a great ability for the eye to be able to dissipate that energy. Now we're increasing that risk for glaucomatous damage. So here's an 8.6. This is a pretty fun one right here. This was an ocular hypertensive patient. I wish I would know the cornea hysteresis, but we can play around with it a little bit. We can have some fun. I don't know the cornea pachymetry of this patient, but we can play around with it. Good scores: 8.6, 7.4, pressures of 22. Look at this: 12.7, 12.9. That is enough to make me exhale. When they go to the cornea compensator, you can see it drops it down to 19.3, 19.4. Let's play around cornea pachymetry. What happens if it was a pachymetry of 600? Man, you're talking now a great cornea hysteresis and a thicker. Man, they're super protected. What happens if it was 500? Now we got one that's higher risk and one that's saying low risk based on the cornea hysteresis. If you look at the power marker or the power ranking of cornea hysteresis versus a pachymetry, the cornea hysteresis wins out. That was really a big theme at the OGS, the Optometric Glaucoma Society meeting. It's been around for years. It's ODs, MDs that, years ago said, we don't care if you're ODs or MDs. We just want to have great patient care, great education. And so the theme was like, okay, I'd rather know the cornea hysteresis as the biomarker. So if this patient had a 500, cornea hysteresis is going to win out because it's 12.7 and 12.9 over the thinner pack imagery. And we would most likely monitor this patient closely. And obviously, unless they had nerve damage or visual field loss and so on and so forth. But if they are a ocular hypertensive at 22, we're going to exhale and say, we're just going to follow you. We're going to use observation as your treatment. Now, the one I have hidden here is no, this is nothing other than when this person got referred to me, they were referred to me as a glaucoma suspect or having glaucoma and needing to be treated. They were classic. They had already had the visual field defect that matched the nerve fiber layer dropout, that matched the ganglion cell. They had it in there. You could see the notching in the glaucoma prone zone. This is like your classic glaucoma patient that got referred to me. And let me just show you what their cornea hysteresis and their wave scores look like. When they came in, their wave score was good. They did a good job here of getting the wave score 8.5, 8.4. Their IOPs, this is when it started to fade, but you can see it here 32.6 and 33 point something, 33.3. Doesn't matter. We're at 33, 32. Now look at the cornea hysteresis. Great wave score. Now we're down at 6.3 and 5.7. Remember, nothing tricky here. This was just a straight, easy, high IOPs, confirmed on Goldman, nerve fiber layer dropout, wedge defects, glaucoma prone zone, GCC, ganglion cell. No surprise, primary open-angle glaucoma. And you could see that the 32.5 went to 35, and this 30 or 33 went to 33.8. Cornea hysteresis was low. Eye's ability to dissipate the energy was not good. Now we have, ganglion cell or axonal loss that matched the glaucoma. All right. What were the questions on cornea hysteresis, Joe, since I'm going to move into some other IOP measuring devices?
Well, I think you answered the question, have you found corneal hysteresis better indicator of risk than CCT? I think you've answered that one adequately. But another question was, what is the difference between hysteresis and corneal rigidity?
Yeah, so cornea rigidity is a whole other instrument. I forget the name of the instrument that is able to measure that. You can go and Google it or chat GPT it. Cornea rigidity is just one measurement of the stiffness of the cornea, and cornea hysteresis is the ability to absorb the energy. So stiffness versus the ability to absorb the energy. Yep, that's a great question that's out there. So remember that cornea is a very complex tissue. So that's why we don't need to be taking one measurement, pack imagery, and saying, "Oh, we're going to adjust your IOP up and down, and now based upon that, I'm going to make a medical decision and treat your glaucoma." Again, we go back. It's a chronic disease. There's many measurements. There's a strategy to it. Acute disease can be very I guess, linear. It could be very, I guess, stepwise through do this, do this, do that. When it comes to chronic disease, it's more of a strategy. Here is another device that I've been playing around with. Met Dr. Frank Falk. He's up in the Connecticut area. He has developed this instrument. He's basically trying to identify those patients that are at risk for stroke, and he's done it multiple times. I just never, luckily, have had that ability to be able to do that. But I'm going to go through this a little bit quick, just for the fact that I just want to talk about another device and some other devices that are out there, because not Goldman is always the way you have to take an IOP. You can use ocular response analyzer. You can certainly use the Falk device here, which is doing aqueous outflow, ocular perfusion, pressure, and IOP variation. It can do tonometry. I like it in the practice to do tonometry. It takes a bunch of readings. You can see an N of 70 here, an N of 64, and it's going to tell you the plus minus ratio, and it's going to give you the IOP that's out there. In OMD here, ophthalmodynamic, this is where he's using it by using the central retinal artery pressure, intraocular pressure. We're going to take a little bit deeper dive here, probably towards the beginning of January. Once this flags the patient, maybe in these normal tension glaucoma and these patients that are metabolic syndrome, and it gets flagged, you send them for a transcranial Doppler, and it can help identify some of the early onset strokes. He's got paper after paper, case after case that he's been able to help these patients that are out there by using it. Where I've also found it useful in the practice is that it gives me, remember, we all said at the beginning that's an outflow. It's able to measure the outflow at the trabecular meshwork, and sometimes it can show us the efficacy. So I've had a patient, let's say that person that I showed you that had a IOP of 32, and they had a low outflow, right? Maybe because that trabecular meshwork is herniated up against Schlem's canal, or maybe it's herniated into the collector channels. Then you lower the IOP, and now you help start to facilitate the outflow. There's been some cases where I've been able to solve where, man, they're progressing, but yet the outflow is being flagged. Aqueous was not able to drain out. So that's kind of a cool little feature on this tonography part of this. So aqueous humor outflow, there's lots that you could do with this device. I've been playing around with it. Again, I told you I have like 6 ways of measuring IOP. I'm like, don't know if I can rattle them all off. I have a TonoPen, Goldman, Aura, this device. I have the eye care devices. I have the eye care home. And there's probably another one out there that's in my practice that I'm not thinking. So, it kind of begs the question, which IOP measurement, should you be doing to treat glaucoma, to manage glaucoma, to diagnose glaucoma? And I think Joe and I have both been approached. I think Joe was first to be approached at one time to write a letter, to some state board or just say, hey, look, when you're treating glaucoma, it has to be Goldman. And, it doesn't have to be Goldman. I would never advocate for that. There's different ways to measure. Maybe I wouldn't do NCT, but, you can use Aura. Like I can't tell you, probably all my glaucoma patients, three times out of the year, I'm just using Aura. I'm not using Goldman. Sometimes I'll spot check with Goldman just to make sure it's on par, but I'm not doing Goldman all the time. So which method is whichever method that you want to use, which one is validated out there to measure intraocular pressure. Just make sure you understand what the test is able to do. Joe, any comments on that letter?
Yeah, what had happened was I was approached by somebody of a state board, and apparently there was a disciplinary action against one of the members of the society for managing glaucoma with something other than Goldman applanation. And they wanted me to opine and give a white paper, and I think they felt that me as an academic glaucoma person at the time would fall on the side of only Goldman. And I think they were quite surprised when I said any FDA-approved device for the measurement of intraocular pressure that is well maintained should be acceptable. And also, I caution that I don't want to see other letters coming out that seem to mimic the devices that were in possession by these board members as being standards of care. So that kind of troubled me. Now, Greg, before you go too far, two questions. Goldman's still standard for IOP? I mean, most people do. I think most people do Goldman, but Goldman, you train technicians, students. It is actually somewhat variable. So I think it is still, quote unquote, a standard or what is most used for IOP in glaucoma. But another question came in just a moment ago, Greg, on the Falk device. Can you bill for serial tonometry as indicated by Dr. Falk, or do you have to do it over 24 hours?
Yeah, he and I've had that debate over multiple times. Is can you bill it as serial tonometry? I do not do it. When I read the definition of it, he's saying that it's serial over, and to me, the definition is that you got to do it like morning, evening, or morning, afternoon, and towards the evening. But yet, he's got papers and he shows and so on and so forth. I, he says yes, I say no. It doesn't mean I don't know who's right or wrong, but yeah, I understand the question that's being asked. I just don't have a strong opinion on it. After being the third party chair for 20 years for the POA, I kind of steer away from it. But he's got some evidence out there that shows that it can be done. That's out
Now,
there.
I don't personally, I don't think 24 hours is the standard. I don't think anybody would do that. But I would give you an example where I have billed. I billed serial tonometry was a primary angle closure suspect, a young woman who had undergone iridotomy and she had plateau iris syndrome, and she had never been dilated, and the LPI was not successful because there's plateau iris syndrome. So we, as Harry Quigley said, sometimes you don't know, you just got to bite the bullet. So I told her all about it. I brought her at 8 o'clock in the morning, measured her pressure, dropped her, checked her at 9, checked her at 10, checked her at 1, and her pressure didn't go up and she didn't go into angle closure. I think that would be legitimate. I could stand by that.
Yep. So. Yeah, and as Joe mentioned, a lot of people want me to say, "What's the standard of care?" They want me to say Goldman's the standard of care. I don't believe that it is. I believe, like Joe said, most people are doing it because standard of care would mean that you have to be doing it. What happens if people just want to do aura? They can. That's what their doctor has chosen. So there are different ways out there to measure that IOP. They're all proven. They're all FDA approved devices. It's just whichever one you feel comfortable about when you're managing and treating your patients.
And to go final step further, I do a lot of medical malpractice work. I've probably done about 200 cases. If a doctor came in front of me or is being sued for using something like an Aura or an eye care and not Goldman, I would stand in support of that doctor, even if it were a plaintiff case. So either way, I would still support what they did because these are FDA approved devices.
Perfect. So I hope that helps out there that if you want to try a different device, you want to get one into your practice, please feel comfortable doing that. All right. I guess I could have been running this polling question as we were having that discussion. But the question here, as we get to it, is going to be, is glaucoma a disease of the macula? Is glaucoma a disease? Yes or no? Disease of the macula.
And chat wise, we're all good.
Perfect. All right. And for the sake of time, we'll just kind of display the answer. It looks like we got the trend rolling in. So I'll display the answer here. And we have 72% saying yes, and we have 28% saying no. So again, another reason why we're here tonight is I want people to start thinking of glaucoma. 72% are. But I want to start thinking of glaucoma being a disease of the macula. And we'll go through and we'll explain, why we're thinking that as we go through here. So what's new in visual fields? I guess my first answer would be sometimes I have a picture of an OCT here. And one of the things that we show whenever we're doing, glaucoma disease management or diagnosis or treatment with an OCT is we obviously look at the nerve fiber layer, but we're also looking at the ganglion cell, right? So the ganglion cell is located where? It's located in the parafovea and the perifovea. So the thickest part of the ganglion cell, or where the ganglion cell is, or where you measure the ganglion cell complex, is in that perifoveal area. And I'm saying foveal, so that must be in the macula. So yes, ganglion cells that die is part, or are found in the macula. So glaucoma, in a sense, is a glaucomatous, or is a macular disease. Now, what is new in visual fields? I'm not sure what is new. It's kind of been around for a while, but See the faster, is a visual field strategy that came out where they turned off the false negatives and they turned off the blind spot monitor. Reason being, false negatives can be high in a glaucomatous visual field, meaning that when the ganglion cell or the photoreceptors are dying, they don't go from living to dying. There's a process of being perfectly healthy to a little bit wounded to more wounded, becoming a lot wounded, coming to the point where they're so wounded that they're just going to die. And I'm going to do on the YouTube channel here in the next few days when I get home is that I have a visual field where it was going downhill. The patient had a trab and their visual field went back up because they took the stress off by lowering that IOP very low. And those somewhat wounded ganglion cell and axons were able to recover and that threshold improved. Now, someone that has early glauc or starting to die, if you threshold and come back, they might not have enough time to recover as opposed to a healthy area of the retina. So I always use the analogy of that, you have a trained marathon runner and they go and run a 5K and they run it in 14 minutes, whatever the crazy time is to run that. They finish it, they run across, they drink a glass of water, they hop in their car, they drive home, and they go cut their grass. I try to run 5K still under 30 minutes, and when I'm done, I'm still huffing and puffing because usually I'm like, okay, I can train a little bit, I can go out and run 3.1 miles, but when I'm done, I'm sucking and puffing and blowing, and I'm exhausted. And where that trained marathon runner, boom, okay, thanks, just had a glass of water, thanks everyone, I'll see you, bye bye, and they're done, right? They're recovered. Someone that has a damaged ganglion cell or axon, when you threshold it, it can't recover as quick. So when you go back and shows the bright light, that's a sign that there could be glaucoma. So false negatives, there could be an indication. Now, false positives are terrible on the visual field. That means the patient's clicker happy, trigger happy. And so that's going to throw off the visual field and throw off the analysis that's out there. So that's why false positive are left on. The gaze monitor is a little bit better to track. So this here is nothing more than the strategy here is a CETA faster. It says it right here. It's a 24-2. You can see that the fixation losses are off. It's a central. You can see the false positive on. They turned off the false negatives, and we're using the gaze monitor to mount to track the patient's eye movement on here. So that's what, in a sense, CETA faster strategy is. Now this is a CETA. This is a 24-2C. And so, meaning that, a lot of the times in glaucoma, and this would be the clinical pearl, is that if you don't have a 24-2C pattern, which I'm going to go over, if you have a patient that has ganglion cell loss and their white on white 24-2 is totally normal, but they have ganglion cell loss. The ganglion cell is found in the macula, and you don't have access to a 24-2C, and I'm going to talk about it here in a second. You might want to do a 10-2. So you could do 10-2s now on glaucoma patients along with the 24-2, because really on a 24-2, it's this cross or this plus that I'm going to, like these four, these four, these four, and these four are kind of your macula type of areas. But that's a big area to be testing to see if your macula is affected. So in a 24-2C here, as you can see, I have it in my practice, they added 10 spots to a 24-2C to be able to see if we can pick up the glaucoma and that you don't have to do two visual fields, a 10-2 and a 24-2. So if you have this in your practice and you have someone that has ganglion cell, or if you just want to do it to look for it, there are plenty of examples out there, plenty of evidence-based medicine. These are taken from these articles. Anytime I see Don Hood's name, he has spent his whole life, in a sense, being a guru or studying the visual field. He's also a great glaucoma doc, but also studying the visual field to understand what's going on. So there's Don Hood's name there, Don Hood's name over here. And you can see here, visual field 24-2. showing that both are abnormal, the 10-2, 24-2. But again, it's only these spots right here that get affected on a 24-2. So you can have a normal 24-2 and an abnormal 10-2. And then the vice versa, your 24-2 could be abnormal, and then you can have a 10-2 that is normal because these spots are normal, the macula, but it's outside in kind of this arcuate area. So again, it's advocating in a sense saying, man, in glaucoma patients that have nerve damage and GCC loss, probably should be doing 10-2s versus and 24-2s. So what they did is they came up with a kind of a nice kind of hybrid visual field. That's the 24-2C, taking the highest important locations from the 10-2. As you can see here, they use statistical analysis on glaucoma patients, finding on the 10-2 the spots that are most likely to be involved, higher than number 1.3, 1.5, 1.8. It was these 10 spots that they decided using statistics, again, using the expert group of Don Hood and other people, and bringing in. So what they added were those 10 spots to the 24-2 in order to get away from having to do a 10-2 and a 24-2. So I thought it was kind of cool. Using some of my clinical pearls here, I put it to test one day. So I had a patient that was in my practice that had a 24-2 done. And I knew that they had ganglion cell loss, and we'll just say that they also had nerve fiber layer loss, but they had ganglion cell loss. But when they did the visual field, those spots did not show up. So I asked Sarah to do a 24-2C, and now we are now picking up some central spots here. So those spots that were added were able to be picked up on this person here. So again, here is the same thing that happened, 24-2 C versus, well, actually, I guess I did it reverse. I'm looking at the times here. I had a couple patients but this is a different patient. See, I had the 24, see at 823, it showed up. And I said, do me a favor, go back and do the 24-2. And look, it was clear. I wanted to see if it would be clear. Look at this here versus this here. It's probably the same over here. Now I'm looking at the times. 817, yeah. And go back and then do it after they did it. So you can see this was 817, this was 823. Then I said, okay, go back. I'm curious. I want to be able to put this in a lecture if it all plays out. And look how it came out clean over here. So would have missed it over here. Well, now grade. So we always say structure versus function. Well, depends on what, this here is a function versus function test. This function test versus this function test. Which one is more, reliable? So that structure versus function out there, be careful with that. It all depends on what devices you're comparing, OCTs, the visual fields, to, color vision testing, the Ray-Ban versus maybe the LKC device, electrodiagnostic devices. Those are all functional tests. So just be careful out there when someone asks you, maybe you just say, what are the two devices, or what are we comparing? All right, let's get into some more visual field. What does mean deviation mean, and how important is it? So I always like trying to teach what these two parameters mean. I'm just going to take it out of the box here real quick and unpack it and just say mean deviation just tells us how deep the defect is. Pattern standard deviation tells us how localized. So this is a very diffuse, scattered throughout the visual field, and the mean deviation mean deviation tells me it's just very, very little deep. 0 is perfect, and we get down just a little bit from 0 at -1. And the pattern standard deviation tells me that it's globally diffuse throughout the visual field. So I could take a look at this visual field, and I'm going to say, okay, if this was -1 and it's -1, that it's a very mild defect and it's scattered throughout the visual field. Remember, glaucoma kind of keeps grinding down in that same arcuate kind of pattern. So what happens is the mean deviation will continue to get deeper because it's grinding away and it's worsening, but so does the pattern standard deviation because it's the same area. It's grinding down in that same area as opposed to being scattered across. So mean deviation of a 5, what does that mean? Well, it's pretty significant. People read slower, don't leave home as much, walk slower, and there's increased car accidents when that mean deviation hits a -5. So the next polling question I'm going to ask is polling question number 4 is what is the mean deviation of a blind eye? The mean deviation of a blind eye. What is it? If we want to know what the mean deviation, I want to know what the mean deviation on a 24-2. What's the mean deviation? Is it 100 decibels, 32? Is it 0? Is it -32? Is it -100? Or you know what? Not sure. I've never considered it.
Hey,
What
Greg, a
is
question
yes.
rolled in. Is ganglion cell loss a precursor to nerve fiber layer loss?
Yeah, so that's always that great question, right? The chicken or the egg? Is the ganglion cell coming first? Is it the nerve fiber layer coming first? Being that been teaching OCT, been in clinic for many years, is it a precursor to nerve fiber layer loss? I've seen ganglion cell. To the answer, yes. I've seen ganglion cell loss first, then nerve fiber layer. However, I've seen nerve fiber layer loss in a perfectly healthy ganglion cell, and then the ganglion cell drops off later. So, remember, this is a disease of that axon or the ganglion cell. The ganglion cell goes through the nerve fiber layer. That's your nerve fiber layer, goes through the neuroretinal rim, goes through the lamina curvosa, goes and becomes myelinated, exits the orbit, goes through the chiasm and synapses in the lateral geniculate body. That axon's a really long axon. There could be maybe damage at the lamina curvosa. There could be shifting there, and that's not affecting the ganglion cell at the beginning. So I would not flip and call one first or the other. I've seen them both happen where you get nerve fiber layer loss in a healthy GCC. I've seen it in a trash GCC in the nerve fiber layer, but one can precede the other. But any thoughts on that, Joe?
I share with most of those thoughts. I mean, ganglion cell, it is part of the nerve fiber layer, so I don't say it's definitely a precursor. It's all in how you can observe. You may observe one differently than others, but they come very close together. Another question is rolled in. Is 24-2C acceptable for glaucoma patients on high-risk meds, or do you recommend 10-2 be done for this group of patients as well? My belief is those glaucoma patients who are on Plaquenil have earned themselves multiple visual fields.
Yeah, so I think I would answer the same way and just kind of use the study that how we ended up with the 24-2. Remember, the 24-2C, I'm sorry, the 24-2C. Remember, they looked at patients that were glaucomatous. I mean, I can skip back here real quick where that was and kind of show you my points. Remember, these points were based on glaucomatous points. So this wasn't Plaquenil patients. So my Plaquenil patients, and I practice right down the road from an 8-man woman rheumatology practice. So I see a ton of Plaquenil. I would still do 10-2s on them. And the reason being because these 10 points were for glaucoma, not for Plaquenil specific. So that's what I would use and be careful with that. So
Yep.
I guess if a patient wanted to, if they have glaucoma, just like Joe said, you're going to do 24-2s, 10-2s, and that would maybe clear your Plaquenil patient too, or you could be doing 24-2Cs and 10-2s. But I would do a 10-2 on a Plaquenil patient. All right, let's display the answer here. So we got 0 people going for 100. We got a few people going for 32. We got some people going for 0. We got most of the people going for not sure, never considered it. Yeah, that's how I was. I remember, and we have 27% going for 32. So that's the answer, everyone. 26% it just dropped. I'm going to say -32. I'm going to close the poll. And here I was, teaching mean deviation, how deep it is. And then someone asked the question, or the question came to my mind, man, if I was sitting in the audience as I was lecturing, I was like, if I was sitting in the audience, I would ask the question is, what's the mean deviation of a blind eye? I can't remember how it played out, whether it was me coming up with the question someone asked, but I remember couldn't wait to get home on Monday. And I walked in on Monday. I start patient at 7:45. I come cruising at about 7:50. And Sarah was there. First patient is ready. It's in room one. And I said, hey, do me a favor. Oh, good morning, by the way. Now, can you do me a favor? Can you go into the visual field unit, turn it on for me, type in minus the patient's age 35, let it run as if they're blind, print it out. I want to see it. And then if I'm not out of the room, do it for age 65. And she kind of looks at me. She's like, am I on candid camera? You really want me to do this? Is it a joke? Or is it some type of initiation, doc? Like, what's going on? I said, no, 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 no. I said, I want to know what this is. So go in to put in age 35, put in age 65, let it run as if the patient is blind. Because I want to know what I want to treat when I'm going for glaucoma. So here it is. Here they are. They're unveiling right here. Here's the 35-year-old. Here's the 65-year-old. Here's the mean deviation, minus 34, minus 32. So I use minus 32 because most of our patients have glaucoma are a little bit older. So minus 32 is the mean deviation of a blind eye. Now, if you look at what I just said, minus 32 tells you how deep it is, but pattern standard deviation is very diffuse. This is a blind eye. It's diffusely scattered throughout the whole visual field, this blindness. So that's why it's low. Remember, as it's grinding down in an arcuate, these could be 7s and 8s, very high on pattern standard deviation. But as the glaucoma starts going superior and inferior, it starts to spread. That pattern standard deviation will come down because it's diffusely scattered. So whatever number you want to use, minus 32 or minus 34, that's what I don't want to get to in a glaucoma patient. I did it for us on the new Humphrey Visual Field 3. You can still see minus 33, minus 32 over here. I'm not trying to get a patient whenever I'm treating glaucoma to minus 32 that's out there. So that begs the question, does someone that is minus 16, are they half blind? And the answer is no, because remember, visual fields are not linear. They're curvilinear. That's why minus 5, people read slower, have increased car accidents, have increased trips and falls that's out there. So I don't want even people to get to minus 5 because of what I just pointed out. That's a 0 to 5 is a mild defect. 5 to 10 is a moderate defect. Anything above 10 is a very severe visual field defect that's out there. All right. Visual field cut, as you can see here. Again, this is a very classic example. We can see here, these are zeros. We got lots of 30s and 27s around here. So when we go and look at this mean deviation, it's minus 11. That's a severe visual field because we're above that 10. But look how localized this defect is. The good news is it's a 12, almost a 13, 12.95. Look at it, how it just kind of keeps grinding down in this area. So we can tell it's very localized, but it's also very deep in this area by telling that it's minus 11 and just 12. That's on there. And we can see here, no, this is a cool one here. You can see this patient's glaucoma was worsening, worsening, worsening. Decided, I think this was one of my patients that didn't want to have it treated until he started getting an APD or dimming. And then we decided, okay, let's treat. And then you can see here, you see, remember those ganglion cells and axons some were wounded, but then when we lowered the pressure, their visual field improved. Now, it's not going to go all the way back up. This will flatten out over time. And I have one that I went for a trab that I'll throw on our YouTube channel. It's just one visual field, well, two visual fields, one on the right eye, one on the left eye. And it's kind of cool because the trabs were done about a year apart, and we started getting the recovery a little sooner than the other eye. And that's why I'm excited to put it out there on the YouTube channel as a quick pearl for us. So you can see what's happening with these mean deviations on this patient. Again, mean deviation, how deep, pattern standard deviation, how localized it is. So this is a fun one. I can give Joe credit for this. He pointed this out when we were teaching the Maryland course for Maryland whenever they passed their Ocular Therapeutics, they hired us to come down and do, I think it was maybe the 100-hour course, Joe. Do you remember what it was? It was something really, maybe it was 30 hours. It was a lot
If it
of,
wasn't, if it wasn't 100 hours, it felt like it.
so yeah. All right. So here it is. Okay. You can't really respond yet. So which visual field does this represent? And I'm going to come back. All right. This visual field that I just showed you right here, -14. Here's a 17. Look how localized it is. It keeps grinding down in this area. Man, that's -14. Which picture does this represent? Is it extreme glaucoma, advanced glaucoma, or is it early glaucoma or normal vision? Which one is it? Is it extreme? Is it advanced? Is it early? Let me go back and show you the visual field. There, here's what I'm looking. Which picture does that represent? Right here. Look at this right here. How would you explain that to a patient? Is it extreme, that picture where it's kind of tunnel vision, a little bit less than tunnel vision, maybe that early glaucoma? Which one would you call it?
I think maybe for the sake of time, we want to wrap this one pretty quick because we're just about at our airport.
So we'll display it here. We got a lot of people going with advanced glaucoma. And I kind of didn't really give you an option of where I was going here. It's kind of maybe not an unfair polling question, or it's an unfair polling question. But you can see a lot of people went with advanced glaucoma. I'll close the poll, close this up, and let me get to the point that I want to get to. Is that these are terrible because remember, we all have blind spots, that are in our temporal vision, but we never see them, right? We don't see these two holes out here. We all can do those little tests that they taught us in first grade of optometry school or second grade of optometry school, where we could see those blind spots, but we don't really see them because your brain fills in. My dad had a right homogeneous hemianopia. He didn't tell me that he had these big black spots over here. He would bump into things because his brain would fill it in and he wouldn't see it. This is how patients see. And this is, again, I got to thank Joe. I just get to go out and use it in the slides. But here is a full visual field. Here is someone with this defect. Well, they don't look like this. They look like this. The brain fills it in. As the person is looking straight ahead, they don't see the children. The brain fills in. It says, oh, I don't see children over there, but I will fill it in with cars and trees. And they don't see the car. They don't see the kids. And someone with a more advanced glaucoma will not see the car, will not see the children because your brain fills it in. These are the pictures. This is why we need to be pulling driver's license or have to pull driver's license or mandated or part of our license to do that, because you'd think, oh, if a person saw like that, they would never get behind the wheel. Well, they will get behind the wheel because they don't see like that. They see more like this. The picture gets filled in. And Joe always says this isn't going to work out real well for grandma because down here, grandma's trying to walk across the road. Grandma feels that she's got the right of way, but someone driving this car has grandma in their blind spot. The brain is filling it in and they do not see her, and it's not going to work real well out for grandma. So again, we don't have to get away from using these types of scenarios that are out there because patients don't see it, the brain fills it in, and we see things like this. So, and I'll just wrap up with this here. He's got glaucoma in his left eye. He has glaucoma in his right eye, not as bad, but his defect down here is really bad. And if you watch, he's going to see it. It's going to turn orange. It's going to go red. It's going to go orange. It's going to disappear. And then when I uncover at the very end, he laughs because he didn't realize that he had a blind spot there. All right. Can you see that red cap there?
Yes, I can.
Okay. It's red, right?
Yes.
What happens here?
It's gone, completely gone.
Make sure you're looking at my nose. And then it's gone, right?
Yes.
See it?
Yep.
You can definitely see it there, right?
Definitely.
I'm going to cover this eye. Is it gone?
It's gone, yeah.
Okay.
I
Keep looking at
can't.
my nose.
Watch what happens.
Watch what happens now. Tell me what happens.
I can see it, but I can't really see the red. It's kind of a shadow tan color, and
Perfect.
it's just starting to turn red. Now I can see the whole thing red.
Tell me when it disappears.
Starting to change colors, and I'm losing it. Sarah.
Okay, thank you very much. So he didn't even realize that visual field defect was there. But I have lots of that can cover, but I'm going to stop because I'm going to respect everyone's time here. So I am going to just kind of go quickly through these slides. I guess I didn't get through a lot, but we can maybe do a follow-up. Here's the new scanner that we were launching. I think it's in here. Right there it is. Handheld. There it is. All right. So, all right, everyone, you should be able to see this little red dot on your screen. That allows you to start doing those polling questions if you would like to start doing, or not polling questions, but that survey that CE Broker and Co require us to do. So please do that, or you can wait for the email to go out in 7 minutes. So, Joe, are there any other questions that are out there?
There are no other questions. A comment came in that said, I think it involved the last visual field you were talking about, the representation. Said, in Alabama, grandma votes. I don't know what it means, but I did chuckle when I saw it.
So, thank you. All right. So if there's no other questions, that was Glaucoma Update, Enough Pearls to Make a Necklace. This was a synchronous virtual course. This is part of our national webinar series. I want to thank everyone for attending. Thank everyone for trusting their education with Optometric Education Consultants. Thanks everyone for attending.